It's tricky because I'll have somebody that comes into the office and they're demanding something. The advantage of particle therapy is it generally goes in and it stops. You get on an airplane, you don't want the pilot up front to be, like, hey, that was the most exciting plane ride I've ever been on.
Yeah.
Right? You want boring.
Analogy.
Welcome to What I Wish I Knew, a cancer starter kit podcast, where I share everything I wish I had known after getting diagnosed. In this episode, my functional medicine doctor, Dr. Dan, sits down with proton radiation expert, Dr. James Urbanik. I completed 33 rounds of proton radiation, and Dr. Urbanik was my incredible doctor throughout all of it. I still remember the day I came out of my last session, and all the nurses and techs, they brought in my friends and they had me ring a bell and gave me a signed certificate and a shirt. And as soon as I came out, and 100%, I definitely melted to the floor and bawled my eyes out. But in this discussion, the two talk about proton radiation, how it differs from conventional radiation, and how to best be prepared for it. The three things I wish I knew about proton is, well, first of all, that it's even an option. To me, it's more precise than regular radiation and doesn't radiate throughout the entire depth of the body. Number two, the best advice I got was that every day when you're inside the alien machine getting blasted with radiation, to visualize and imagine that every wave is hitting the body directly, healing it, eating away the cancer, and visualizing its effect in a positive way so your body and mind know that it's safe and that it's working. Maybe it's woo-woo, but there's no downsides to this way of thinking. Number three, moisturize, moisturize, moisturize. That area being radiated will thank you. And this episode, we will go deeper into other things to consider during the time too. All right, here's Dr. Dan and Dr. Urbanik.
Dr. Urbanik, welcome.
Yeah, hi, nice to see you.
So tell the audience a little bit about who you are and what it is that you do.
Well, I'm Jim Urbanik. I'm a radiation cancer doctor. I'm here in San Diego at the University of California. And I treat lots of different types of cancers with radiation therapy of various types.
Perfect. And we'll definitely dive a lot deeper into that. But before we do, I just wanted to get into a little bit about your background in medicine. So what sparked your interest? How did you get into medicine? And then how did you get into cancer care?
Yeah, it's never linear, right? Your life, it goes in a lot of directions. I went to college originally to race sailboats, so it's pretty random when you're 17 years old, the decisions you make. And so I did that. I went to the U.S. Merchant Marine Academy at Kings Point. And then I basically went and worked on ships for a number of years. I worked as a navigation officer, deck officer, and as an engineer. And kind of felt like I was just popping up around the world as, on tankers, oil tankers, container ships, and kind of not having a real impact on anything anywhere. So started thinking about how I can get back to school and how I can maybe do a career that does a little more give back to it. Long story short, got my act together, saved my pennies, went to medical school. My parents had long moved to South Carolina, and that was my address. That was my state school, and so landed in Charleston for a number of years for my education. And then, frankly, my landing in cancer care is all about the people I met along the way. So my college sailing coach had passed away from gastric cancer, when I was still going to sea for a living, and he was close to me, and so that kind of left an impression. And then when I was at the Medical University of South Carolina, I had some really wonderful mentors who basically, when I was looking for projects and things to do, were so gracious to, give me their time. So they got me started in both medical oncology and then ultimately in radiation oncology, spending time with them. And I was kind of sold. Radiation for me as a former engineer is a perfect mix of high-tech equipment, right, computer-aided design work, and then the medicine of trying to help people. So,
interesting way that you've come into the medical field. But that is interesting. The engineering background and what you do.
Yeah.
And doing my homework that we'll get into in a little bit. The proton therapy is quite the engineering feat.
Yeah, so, all the different pieces of radiation, whether it's X-ray based treatment, proton therapy, or, whether or not we're using actually radioactive pieces of metal, the science of engineering, and then, that combined with the biology of medicine, it's a really interesting, two-pronged world that I live in. And so my background, working on big ships and big power plants actually oddly set me up pretty well to be pretty comfortable around that kind of equipment.
Definitely so. Let's take a little bit of a step back because I know a lot of our viewers are maybe very new to cancer. Mm-hmm. They might have heard the terms radiation or chemotherapy thrown around, but don't necessarily really know exactly what they mean. So maybe let's just start with, generally speaking, what is radiation as people normally hear about it?
Yeah, so radiation for most people is pretty scary. It's a scary concept, right? We're thinking about terrible events in world history, and sort of uncontrolled aspects of radiation can be pretty rough on people. Whereas we're trying to use radiation in a very controlled way. Mm-hmm. So radiation essentially is using energy. Without getting into proton therapy for a second, classically X-rays or radiation from a metal source is using a wave form of energy somewhere along the spectrum that includes light, includes microwave, includes radio wave. It's just these are very high energy pieces of the spectrum, and by aiming them at cancers, we're trying to basically cause injury or damage, right? And then by trying to focus on the cancer, we cause injury, hopefully in a way that kills the cancer, and then we have to come up with ways to minimize the damage to the things nearby. Right. And so that theme really continues from the simplest forms of radiation all the way through to the most complex ways that we do it. So basically manipulating energy to aim at a tumor in a way to cause an injury to the cancer. Mm-hmm.
And is the goal of that typically to cure, to control the disease, to relieve symptoms?
Yeah. So the goal is layered, right? And it's going to depend totally on the patient's situation, right? So, when I'm working with residents, I try and remind them that, our first job is to make people feel better, right? Yeah. So that's kind of job number one. And then we have to figure out how to kind of meet them where they're at to do that. So, for a patient with very advanced cancer that's, not curable, you try and have an honest conversation that the goal of treatment is maybe to relieve symptoms, but isn't going to cure them. There are other patients that do have, metastatic disease where, they have a small amount of disease that's outside the original area. And we may actually be trying to prolong life by picking off the visible disease. And then we have the other layer of patients where they have a tumor that's maybe taken out by surgery, and we're just the cleanup hitter after the surgery's been done to try and sterilize the area, if you will, from any cells that might still exist. Or sometimes we're the main treatment for cancer. There are a bunch of cancers where we're not doing surgery for oftentimes the reasons that the surgery would be very, very harmful. And we're using radiation treatment as the primary treatment to actually try and cure the patient of their cancer, which sometimes is straightforward to do. Sometimes the odds are not good. Mm-hmm. So,
can you tell me a little bit more about that in terms of the what types of cancers you wouldn't be wanting to do surgery, that you'd only want to be doing radiation for?
Yeah, so you think about things where we're trying to do organ sparing. So a classic example of that is the voice box or the larynx, right? So for some early larynx cancers, you can do surgery quite nicely and just get the tumor right off the vocal cord in a very, exact way. But there's that big middle ground of tumors where they're not so advanced that the voice box just has to come out anyway. But maybe we can try and spare the voice box and keep them speaking, keep them swallowing. We're going to do radiation instead of surgery to remove it. Another example would be, other than very early cervix cancers for that GYN malignancy, most cervix cancers are treated with a combination of radiation and chemotherapy. Anal cancers, oftentimes for the same reason of trying to preserve function in a way that surgery can't. We actually provide very effective curative treatment for that. And then in other cancers, we're balanced with surgery where nowadays, in 2025, we're able to do smaller surgeries than maybe we used to, right? So, in 1960s, early 1970s, all women would have had a mastectomy for breast cancer. Now many women can have a smaller surgery and radiation. For many sarcomas, in the 1970s or even in the early 1980s, people would have had to have an amputation for sure for certain things, and now we can do a smaller surgery and radiation treatment. So, we're able to sort of work in a team-based way like that.
Kind of leads right into my next question, which was, how has radiation treatment changed over the past 10, 20, 30 years?
Yeah, so, I've been in the field 20-ish years at this point. And it's changed incredibly in my time, right? And then I would imagine docs who were retiring 20 years ago would have said in the 20 or 30 years in their time before that, it had changed in an intense amount. And I think as you look at sort of just the layers of technology and doing that, it's been the precision has gotten better on one hand, and that includes imaging, in terms of being able to see what we need to aim at.
Right.
That in terms, our ability to line up and aim at something on a daily basis and hit the target, our accuracy has gotten better. And then our ability to, with very powerful computers, to calculate the radiation dose in a very exact way, we can now do in ways that 20, 30 years ago we couldn't do. So for example, when I was planning a head and neck, a tongue cancer case back when I was a med student or a resident, we might have set up the iteration of the plan we wanted to run to a bank of computers and then gone home overnight and then basically come back the next day to get the result of that iteration. Now we can run, a single iteration in a matter of a couple of minutes, and then tweak the plan and then run another iteration, a few minutes later. And so we can create a lot more refinement, whereas before you would have to accept results just based on the constraints of, time and ability. So it's amazing. And so, and then the last layer of that is the engineering. There are things in terms of manipulation of, the actual machines themselves, the ability to manipulate the dose very finely, that we couldn't do 20, 30 years ago. It's pretty remarkable.
So more of like previously like a shotgun almost versus almost like a sniper rifle, it seems.
At times, so the way to think about it is the more doubt that we have about what to aim at, the bigger we have to treat, right?
That makes sense.
And, because you're trying to do what you can to help cure the patient or slow the cancer down. And as we've been able to refine that, and then in turn, the side effects go down. So in some ways, we've been able to amplify the dose, increase the dose, so hopefully the effectiveness, but not always. But a lot of what we've been able to do is try and make the side effects of treatment. They certainly don't go to zero, but to mitigate them as best as possible.
Just due to the accuracy of the treatment?
The accuracy and the refinement of the treatment, yeah.
My next question, which I think a lot of people can resonate with, a lot of people, especially here in Southern California, very natural-minded folks, eating organic, caring about their health, just wanting to go as natural as possible. What do you say to somebody that comes in or that, may benefit from radiation or chemotherapy? Let's maybe just talk about radiation. They say, I just want to go all natural. I don't really want to do chemo or radiation. What would you say to somebody like that?
Yeah, so that comes up. It comes up here in California for sure. It definitely came up when I was working on the East Coast. It's definitely a question that people have. So sometimes you try and do it from patience. You try and be patient with the person. As I get older, I seem to get more patient with people, which is probably true for all of us. Somebody is adamant about not proceeding forward with treatment. I might try and inch them along with, well, hey, how about we come back in about 2 or 3 months with another scan? try what you're going to try and do what you're going to do, and then let's reassess it at that point, right? And just be very open that if something changes in the meantime, you're free to call, free to reach out, and try and bridge them through the question that way. Sometimes I work with anecdotes, of other patients. You can never be specific about people, but you can talk about, other patients who've had some success, but oftentimes not had the success that they wanted to by foregoing, recommended treatment. Talk about what I'm trying to avoid is missing a solvable problem, right? If somebody has a terrible problem that I can't fix and they're really just looking for symptom relief, then we can just wait until you're ready to move forward. But if somebody has a curable problem and the cure is dependent on some degree of time, then you have to try and be a little more emphatic with talking about other cases that you've seen and how they affect you, because sometimes people approach it from an accusatory standpoint. They think you're in bed with pharma. You're only doing it because you work for the university or those people, them, the unknown they, and you try and give them a sense that you're human. You wouldn't be sitting here recommending treatment if you thought it was going to hurt them and not be helpful. Right. I think if you can humanize the interaction, then people tend to be more willing to work with you.
On that note too, I'm just curious, what maybe a rough percentage of the time would you say there is a time sensitive situation that you feel like this is a curable situation here, or at least how often does something like that happen?
In terms of somebody not wanting treatment and trying to go the natural route for a while, hard. I mean, from my perspective, more often than you would think. I would say I probably see somebody every 6 to 8 weeks that comes in sort of with that mindset that they're gonna, go a different route. Of those people, somebody with something that's so rapidly growing that you're really concerned about their safety is actually pretty unusual. It gets back to the old idea of when somebody says, "Doc, how long have I had my cancer?" There's actually a good paper written by a colleague of mine at University of North Carolina who looked at folks who had surgery, no other treatment, for lots of good reasons, and then recurrence, and it generally took about 18 months. And so that gives you kind of a little insight across a broad variety of cancers that on average, a cancer's probably been brewing for a year to a year and a half. So for most things, you've got a little bit of time to work with somebody and try and see where their needs are at. And I would say of the folks who were treatment hesitant, I would say probably 85%, this is just off the top of my head, probably ultimately come back and get treatment.
Got it.
Yeah.
Come around. Okay. Maybe on that note, what's one of the biggest myths about radiation that you feel like needs to be busted?
Oh, well, I think that it's inherently dangerous, right? I think it's just, and it's a tough one to bust, right? And you try and be upfront. There's Hiroshima and Nagasaki and Fukushima and the scare of 3 Mile Island and Chernobyl and on we go, right? And those fears all resonate with people. But you try and give them a sense that we're very interested in process. So,
what do you mean by that?
As we go through the radiation planning process, so like I'm pretty stiff right now because I'm on a podcast, but I'm a pretty casual guy. So I tend to talk to people kind of like they're normal people, and trying to meet them where they're at. But the process that we have, even though I'm, fairly, relaxed, is actually fairly rigid and driven by safety, doing things every time the exact same way as best we can. And having those processes in place not only is what we need for for the safety of what we're doing, but it also gives them a lot of confidence that we're trying to do everything very methodically every single time. So not always perfect, but
Sure.
That's the best method.
Mm-hmm.
Yeah.
Reminds me of a book, another MD, Atul Gawande.
Uh-huh.
Believe the checklist manifesto. I think it's more of a surgery type thing, but just the importance of those, standard operating procedures so that the best safety outcomes are.
Yeah, that's been a pretty influential book in medicine.
Mm-hmm.
In our field, we definitely kind of have subscribed to that idea, probably even long predating Dr. Gawande's book on it. He's coming at it from a surgical standpoint.
Mm-hmm.
And partly because for us with radiation, the fear for me is when I do radiation, I don't know the outcome of what I've done until long after I've done it. Right. So, radiation goes on, it happens, right? And then the effect of it in terms of both affecting the cancer can take weeks or even months after we're done. And then the side effects that the person experiences can occur over weeks, months, and even years. And so, what I end up being worried about when I go to sleep at night is, okay, is the treatment that I'm doing for someone, too much or even too little, right? It's those things on the edge. If it's a very standardized thing, that, is highly regimented, that's one thing. But if it's something that's a little, on the margins, those are the things that cause me to lose sleep at night.
In terms of the type of cancer, the location, the age of the patient?
All the above. Age can go into it, location, near things that may be affected over the long haul that, we're just not seeing in the short term. All those things, and age is a double-edged sword because the age of the patient, you want to make darn certain you're curing them, but also you want to make darn certain that you're not causing undue long-term side effects.
Sure.
It's a really tough one.
Tough position to be in.
Yeah.
Let's talk. I want to get into proton therapy.
Sure.
So maybe for the folks listening, what is proton therapy? And on that same note, why do some people call it the future of cancer medicine?
Yeah, there are lots of questions about it on that one. So proton therapy, it's particle therapy. Okay, so when I think of radiation treatment, to back up even further from that, we have treatment with external beams. Okay, which classically is called teletherapy, tele meaning far, and then we have radiation from metal objects, pieces of metal that we put into the patient. That's close therapy or brachytherapy. So we have that dichotomy. And then within teletherapy, we can either use a wave form of energy, which is X-rays or photons. I tend to call them X-rays because the language is a little further than protons, where it's just one letter different.
Sure.
So protons, carbon ion, neutron therapy, these are all using either neutral or charged particles to basically deliver the energy towards the cancer. So why would you use one or the other, right? And so the advantage of particle therapy is it generally goes in and it stops, okay? So with a proton treatment, if there's something deep to the tumor that we're trying to hit, we can do a pretty good job of trying to miss it, okay? And when I say a pretty good job, it's not a perfect job because when I say it stops a bit like a hockey player sliding to a hockey stop, right? It's not right away. And as it's stopping, the analogy, the physicists are going to start screaming at me, but it gives up its energy kind of like a hockey player is when he's stopping, right? And so it's at that end of the stop where the big spike in energy occurs from a proton. And so we can manipulate where we put that. And that's called the Bragg peak. And then so by basically treating in layers, we can treat the area that we want with proton therapy. So that has a lot of advantages for some patients. X-ray treatment is a wave form of energy. So kind of like an ocean wave, a sound wave, a wave is going to go through something, a medium for a small distance before it gives up its energy, right? So it's going to penetrate and be giving up its energy as it's going through, but the wave will continue all the way through, right? Usually with less energy than when it started, right? So with X-ray treatment, we have to come at something from lots of directions because of that. So I always get a little on edge when we talk about one way is the future over the other.
Sure.
Because when I explain it to patients, I talk about it as, particle therapy, proton therapy is a tool in my toolbox, just like X-ray treatment is a tool in my toolbox. And I have some patients where proton treatment is a slam dunk. I have some patients where X-ray treatment, frankly, is a slam dunk for them. And then I have this huge area in the middle, which is a big sliding gray area, closer towards the advantage to proton or closer towards the advantage to X-ray, but a lot in the middle where, frankly, it doesn't matter. And yet I try and be very, very honest about where folks fit on that sort of spectrum of which tool I tool in my toolbox. And then it's tricky because I'll have somebody that comes into the office and they're demanding something. And I just sort of, sometimes I'll look at them and say, hey, if you called the plumber over to fix your sink, would you stand over them and tell them which wrench to use? Right? Or are you going to trust me to try and pick the right wrench for the job?
Right.
And then, because that usually will help to kind of temper the situation, but not always.
Sure.
Right, for sure.
People are coming at you probably from ChatGPT. They're got their MD on either Google or ChatGPT.
Or there are a lot of really smart people out there. There are a lot of engineers out there. There are a lot of just people who are well informed. I treat a lot of doctors. Doctors get sick too.
Yeah.
And you just try and help. Half my job is education, right? Whether I'm educating residents or more, pointedly educating patients about what we're trying to do and why we're trying to do it and which tool we're trying to pick in the toolbox.
So I think you did a really nice job. That was going to be my next question, explaining photon or X-ray therapy, which is what we typically refer to as standard radiation,
right,
versus the proton therapy. So let's talk a little bit about when the difference between the two therapies matters.
Yeah.
In terms of either effectiveness and outcomes,
right,
symptom severe, side effect profiles.
Right.
Maybe walk us through some of that.
Yeah. So that's always the easiest place to start is where are things just clear cut.
Right.
Right. And of course in medicine, even things that are clear cut are never 100% clear cut.
Sure.
Probably, so proton treatment, right? So just keep in mind, we're able to spare things on the other side of the tumor, okay? So is the way I think about it. So the classic example for proton therapy would be a child's spine tumor, right? So there's some cancers for children that are curable, and we have to treat, in fact, their entire spine, right? So in front of their entire spine, all the way from their neck and all the way down, is their heart, their lungs, right, their esophagus, their intestines, all of that. So with proton treatment, we can basically minimize the dose to that. But even beyond that, we actually, if it's a growing kid, we actually can treat only half their vertebral body nowadays. So
really,
we can allow them to grow to a near normal height. They'll get some wedging of their vertebral body, but they'll still get a fairly normal height in terms of their growth from that, which is something we weren't able to do before we had proton treatment. Super important. And then we're also able to minimize dose to their reproductive organs. So chemotherapy is a whole other issue when it comes to reproduction, but at least from the radiation side effects, we're trying to minimize the impact on their ability to become parents in the future. Right. All those sorts of issues. Heart disease. The other one would be in both, I think, in adults and children with slower growing brain tumors. So like, what does that mean? So some brain tumors grow so quickly that the honest answer about the intent of treatment is we're really just trying to slow it down. So the long-term, potentially subtle differences in how their brain functions probably wouldn't be statistically detectable. There might be some slight difference, but you probably wouldn't be able to pick it up in any kind of neurocognitive testing, right?
In terms of if you're doing an X-ray
X-rays
or
protons, right?
Got
So
it.
somebody with
Got
a
it.
terrible off to the races brain tumor, right?
Yeah.
And somebody who has many brain tumors where they have potentially years or even decades of life expectancy, those subtle differences are going to amount over the course of years and decades. So slow-growing brain tumors, the advantage of treating less brain is going to come up with proton treatment for sure. It's going to be a pretty good opportunity for folks. The other one, because I do a lot of chest oncology, that's sort of been my a bit of my subspecialty over the years, would be tumors that sit in front of the heart. The heart, in the way I think about it, kind of as an engineer, it has a beating pump part of it, it has an electrical part of it, and it has the blood supply to the heart itself. And so sometimes we're able to minimize the radiation dose to either one or all three of those components of the heart, and then the valves on top of that, to try and minimize some of the heart disease risks from radiation that we would get with x-rays over protons. So I treat a fair number of patients with tumors kind of right here in the middle of the chest as well. So those are, to me, obvious, easy sort of slam dunks. The slam dunks for x-ray based treatments are kind of the opposite. They're going to be things that sit in the middle of organs that tend to be fairly small and maybe mobile. Right? So, for example, a small mobile lung tumor is going to be better treated with an x-ray based plan, because with protons, something that's moving, we get very nervous that the proton's just going to go shooting right on by the target, right? Whereas x-rays, we have a little more forgiveness in sort of handling that motion issue.
When you say mobile, you mean the actual organ is, like, I'm assuming with the
person's
lung,
breathing.
The person's breathing. You can't really
You can't stop them from
stop
breathing.
them from breathing.
Yeah, although people have looked at that kind of idea of stopping people temporarily from breathing and then having the treatment be so quick. I mean, there are definitely research avenues down that line, but in terms of what we're doing day to day, kind of in the clinic, that becomes an issue. The other issue is sometimes in very, very small brain tumors, where they're getting too far into the weeds. Sometimes the radiation dose distribution around very small targets actually looks a little better with x-rays than it does around protons. So we're able to do very, very small things a little bit better.
Meaning the proton therapy might miss?
No, it might give a bigger spot of the high dose area. Our ability to be so refined to such a small area, sometimes we can actually do that a little bit better with some of the x-ray based techniques. It gets pretty weedy to try and explain that without charts and diagrams, but it's actually kind of fascinating, right? And then in the middle, I try and be very honest for people when they're in the middle, and it probably doesn't matter, right? We have those conversations all the time. So,
right. Actually just answered my next question. But who would be a good candidate for proton therapy, who might do just as well with photon therapy. So on that note, pros and cons of doing proton therapy versus x-ray therapy. I know obviously the proton therapy can be very, very expensive, or at least to my knowledge. Why is that the case? Why is it so expensive? And then can you talk a little bit about insurance? Does insurance cover this type of intervention?
Yeah, so lots of directions to go on that. So the complexity in the United States as to why one healthcare piece is more or less expensive than another healthcare piece is really hard to figure out, okay? But I would start with the cost and complexity of proton therapy is honestly something I take into account when I'm talking to patients, right? So if I have somebody where it's a real wash what type of treatment they're going to get, then I'm going to be very careful to explain to them that, the complexity of proton treatment is more, the scale is bigger, and the difficulty that we have to deal with, sometimes engineering issues that come up of downtime or delays, is important. So if I can put somebody with something that I think I can treat equally effectively and equal side effect wise on an x-ray machine and do it in a 12-minute block with 99% uptime and off we go, that's going to be the better tool as opposed to trying to deal with some of those other complexities. The scale is something to think about. The gantry of the proton machine weighs about as much as a 737 airplane. Okay?
What is a
gantry? Is the part that rotates around the patient. So that's just one component of a proton center. We can get into the nuts and bolts of it, but whereas the radiation machine, a linear accelerator that rotates around a patient for x-ray based treatment, is kind of like a big dually pickup truck or maybe a small dump truck in terms of scale. So we're talking just huge differences in orders of magnitude. And so as you increase that size and the complexity of engineering systems to do that, you can see where you run into, your car starts up every day, but how often do we go to the airport and the pilot says, hey, wait a minute, we've got to deal with some complex engineering fix for the airplane, right? It's the same kind of issue there, right? So that also goes into this question of why is proton therapy more expensive, right? So building them is a lot more expensive to do because of the size of scale, complexity. Here in California, we have earthquake standards that we have to meet, so those add to building costs. And then staffing-wise, we actually, like at the Proton Center here in San Diego, we actually have full-time engineers that are on site to handle a lot of the behind-the-scenes work that goes on to keep the place both operating as operational engineers and in terms of maintenance, highly complex. Whereas for a linear accelerator, standard X-ray machine, there are folks that work for a variety of companies here in San Diego or any other big city that if we need them, we call them and they come in on a service contract, but they're not standing there ready to go. So it's a whole different layer of scale.
Got it.
So you have those issues. So then the companies or universities that are running proton therapy are trying to recoup their costs, right? So the cost of the therapy ends up being potentially more because of that. Sure. The push and pull for what patient sees is what is insurance going to cover, right? And that often gets into both what they're going to be willing to cover in terms of both in-network and out-of-network, and then whether or not they're going to let them get that treatment for that indication, right? So the amount that they'll cover, but then whether or not that indication falls into their rubric, right? And so we deal with a lot of those issues. And so that's why when I talk to patients, I try and be very clear about the goals and the intent and why we're doing it. So we're never throwing the baby out with the bathwater, that if we don't get to do treatment X versus treatment Y, that we always talk about we have a good, solid backup plan in place as to how we pivot. I don't know how to solve the reimbursement issue, in the United States. But I have some ideas, but it's a pretty thorny one for us. I will say that I've been at the Proton Center here in San Diego for 10 years, and our work with insurance companies has paid off. The field has grown up in 10 years. More payers are willing to pay for treatment for a broader range of indications. So we're doing better. So I think for patients out-of-pocket costs, they're coming more and more in line, so it's a little bit agnostic to them as to which type of treatment they get. But it's also partly my responsibility to be a good steward in working with payers that I'm trying to, get patients onto the appropriate treatment. And, that's also part of how I maintain my reputation, is trying to work with the patients, but also who's paying the bill. So.
Are any patients paying out of pocket for something like this? Or, I'm just curious, what does a treatment like this cost?
Yeah.
Roughly?
Yeah. Well, that's a tough question. What does it cost, right? I can just tell you that the percentage of patients that are pure out of pocket with no nod to their insurance at all is in the single-digit percentage for us, right? Which may actually be sort of news to people in the sense of they would perceive that it's a lot of people who are paying. But that's because the cost that we would charge is going to be, depending on what we're doing, tens of thousands of dollars. So obviously as a physician, I'm fairly successful, but for one aspect of my medical care, outlaying tens of thousands of dollars is not super feasible. So the percentage of people doing that is actually very, very small. We have different programs in California. We actually have a reasonable insurance situation where if we have a patient where we feel like we really need to treat them with protons for a variety of reasons, and insurance is not doing it, what we'll try and do is figure out if they're in-network or out-of-network, and then try and make the patient only responsible for what their normal in-network component would be for that care, knowing that we're going to fight the insurance company on the back end to get authorization and approval. And then in California, we have the Department of Managed Care, where we've taken a number of cases too over the years, where they'll actually review the case, and then they'll mandate to the payer
I see.
They can't do that for all the federal plans, but for a lot of plans, they can mandate that the payer then covers the care. So the patient stays blind to some of that, where they've only been responsible for their out-of-pockets.
Right.
But it allows us to recoup the broader cost of care in order to try and, because we have to keep the lights on, right?
Sure, for sure, yeah.
I mean, it's a business in some ways, right?
Yeah, definitely so.
Yeah.
That's a great answer.
Thanks.
Yeah. So I think maybe proton therapy on the flip side of X-ray therapy or photon therapy might be overhyped at times. What are maybe some myths around, or some of that overhype around proton therapy that need to be quashed?
all of the above, right? And it's I'm going to give you the answer that probably a lot of doctors would give you, is that medical marketing drives us bananas, right? Whether it's pharma marketing pharmaceuticals, or device companies marketing various aspects of care. The same nonsense occurs with proton treatment, right? You go to a center's website, any center, right, and you think you're entering the mythical promised land of no side effect therapy. And I think it would be better if they really tried to say, hey, proton therapy might be an option for you as a way to try and minimize your side effects. Important component of your care, you need to talk to your doctor and kind of leave it at that. Yeah. But it then takes on a mind of its own. And I've had patients where I've looked at them square in the face and I said, hey, and they're coming from a distance, right? So, not a local person. And I say, hey, I don't think you need to travel to see me, because I don't think this is any better for you. And they'll look me right back and they'll be like, no, we're coming.
Interesting.
Right? And, at some point you're like, well, my ultimate job is to provide you the care that you need and make you feel better. And if helping this person feel better is that they're getting the care that they perceive is the quality argument for them, then, I'm not going to try and beat them over the head with it. But I'm usually very, very clear that, hey, we have other options for you. And that's where you're fighting the marketing, right? Because they'll be basically, reciting the marketing back to you. But that's come up in, almost all aspects of medical care, whether it's proton treatment or otherwise, is where stuff gets overhyped. And I think that gets into the availability has to be there for people. The insurance coverage needs to be there. And over incentivizing physicians one way or the other has to be mitigated, so people aren't pushing and pulling people in one way or the other, for sure.
Let's change gears maybe a little bit, and because I want to touch on what is SBRT, which is stereotactic body radiation therapy,
right?
And then also the SRS, which the stereotactic radiosurgery. So I'm sure people may have maybe heard those terms, SBRT, SRS, don't necessarily know what they mean. So can you break those terms down?
Yeah. So to even take it kind of a layer back, so we've been talking about protons versus X-rays, right? So we're talking particle therapy versus a wave form of energy. So when we start talking about those issues of SBRT, SRS, IMRT, VMAT, those are all now technique questions, okay? So we've got what modality we're going to use, protons or X-rays, and then how are we going to do it, okay? And we can do any of those techniques with either method of delivering the external beam to the patient. So broadly speaking, on the sort of left-hand side, we have what we call 3D conformal radiation, right? So we basically take a CT scan, we draw out what we're aiming at, and then we use fixed beams, kind of like a fixed flashlight beam, to aim at the tumor from one or even several directions. Okay, so there are a lot of complexity to it, but the most straightforward way that we do the treatment. And then sliding over a little bit more to the right on that scale, we have intensity modulated radiation treatment. Okay, so that's where we're able to basically manipulate the shape of the beam from any of the directions that we're using. And we're able to change by manipulating the shape of the beam what gets treated and how much from all those different directions. Okay. And so if we're treating someone over a long course of treatment, it allows us to basically curve the dose distribution is what it is really letting us do. So that's IMRT. And so the equivalent with proton therapy is IMPT. Okay. So sitting there for a second, one of the challenges in the proton world is we have some older centers in the United States that are only able to do the equivalent of 3D conformal proton therapy. And then we have the newer centers that really have been built since about 2012 or so that are able to do IMPT. So even within the proton world, we have a bit of an evolving technology. And then sliding over to the right from IMRT and IMPT, we have SBRT, which is where we can do several radiation treatments. And this is where the complexities of the U.S. billing system gets in there. So SBRT limits us to 5 treatments, which is frankly completely nonsensical. 5's an arbitrary number. Why not 6? Why not 4?
Sure.
Like, having been in the field for many years, it's made up, right? But it's it's a line in the sand. But it's where we're going to do smaller number of treatments. IMRT technique generally, although we can do 3D SBRT, but tight dose constraints around the nearby structures, and a really steep dose gradient from the middle of the tumor to outside of it. Okay, so very fast fall off. So we're going to hit something hard, quick, and get out. So that's SBRT. And then SRS is really the same thing, except taken to the nth degree where we're doing it all in one treatment, right? And so all of that plays into how do we pick why we're doing something to begin with. So if you looked at, say, somebody has a really, really small tumor, and I can take a big sledgehammer to it with all that energy and hit it all at one time, and I can demolish the tumor. But because it's so small, it's very little normal tissue that we're treating. But if I have a large target and I was to take that same energy from a sledgehammer and do it all in one treatment, I would destroy all kinds of normal things nearby. And so that's why we break up treatments into those smaller individual ones. But the technique of SRS is just one treatment with the whole ball of wax all in one big hammer blow to the tumor. So brain tumors are a great example of how we do that. Really small tumors, brain metastasis. Sometimes we do some functional neurosurgical techniques. Somebody has a tremor and they can isolate the part of the brain that's causing the tremor. They can try and ablate that. Some facial pain scenarios, we can try and aim at the nerve to try and deaden the nerve for them. We can do it all in one big whack to do that. But obviously, when you do it in one treatment, the risks of missing need to be taken into account.
Right. So if I heard you correctly, it sounded, simply put, obviously, the larger the tumor, the more repetition you might want to go at it with versus the smaller, maybe attacking it with the SRS,
right,
on a single dose. Okay.
Right.
Okay.
Yeah, and it's also going to depend on what it's near. So, for example, if somebody has a tumor in the middle of their liver, and the liver being this large, somewhat redundant organ, I can treat that tumor to a very high dose of radiation, and the surrounding liver gets some radiation, but there's a lot of other liver that can sort of recover that injury.
Sure.
And they'll be okay.
Sure.
But if I was to take that same tumor and move it over, a couple inches and put it in their pancreas where it's surrounded by the small intestine, I can't hit it as hard, especially not in that short a number of treatments. So I then have to go longer and slower and potentially even less, right? And so that's part of the issue there.
So less intensity per treatment?
Less intensity and sometimes less total intensity. right? So we can treat things that if we can, get rid of something, right? It's there's nothing extra in the human body, but where we have some redundancy, then we can hit it really, really hard. But if something's right on top of something that you can't get rid of, you have to try and keep the thing you can't get rid of working.
So it's in essence weakening the cancer to a certain level,
Yeah,
while trying to spare the other organs.
Yeah, so it may slow the cancer down. It may not be completely curative. We may be pushing for more risky surgery in that situation. Like if I have to pull my punch, then I'm going to need the surgeon to take more risk, right? Just like the surgeon, if they see a situation where I can help them not take as much risk, they can back off as well. So that's why it's a partnership, right? We never want to have a radiation doc that kind of lives in a vacuum.
Right. Not to get off in too much of a tangent here, but I did interview somebody last time actually about immunotherapy, and I think I heard you in a video talking about the combination of immunotherapy, or same thing, chemotherapy or surgery, kind of the multi-pronged approach.
Yeah.
Can you maybe talk a little bit more about that?
Yeah. So immunotherapy actually has a lot of partnership with radiation treatment. And there are tons of research directions we're going with that, but there's also tons of practical, like today, things that we're doing with that. So immunotherapy in my eye, right, is cancer cells are abnormal. For some reason, that abnormality has been able to stay hidden from the body's normal defenses. I mean, I don't want to make it into a cartoon, but that's a little bit of how I think about it. And then with immunotherapy, we're trying to basically either uncloak the tumor so the immune system can see it, or just goose the immune system enough that it can recognize it and start doing its job, right? And the holy grail is prevention of cancer, right?
Sure.
But the next layer is, gosh, if we can unlock the immune system in a way that the body can handle to eradicate tumors, amazing, right? And we have some examples of that. I started my career 20 years ago. A stage 4 melanoma patient, that was a death sentence. 25 years ago. Now we have patients that I know that are around years later, and we're always careful to hang the C word on that.
Sure. But
they seem like they're doing awesome. Right? You can't promise that to everyone, but there's clearly something going on there. So immune therapy, right? So the basic idea is unlocking the immune system to help us fight the cancer, right? So super important component of treatment. How does it fit into radiation? Well, we can either use immune system to help us shrink the tumor early on and give us a smaller radiation target, or we can use it after the radiation to try and, again, clean up, hopefully, the small amount of residual that's left behind. The piece about radiation that's interesting is by causing injury to the cancer cells, we may be releasing proteins, cellular debris, into the body that then actually can help to stimulate the immune system. So if we can do that in a way that partners with the immunotherapy drugs to then find those immune stimulants, and create a sort of antigen-antibody kind of relationship there, then perhaps it can actually help the immune therapy to work better. And that's played out in some cancers. We're using immunotherapy in some head and neck cancers now to advantage. But it's also, the research is super important. So, for example, in lung cancer, we think immunotherapy is super important in a lot of lung cancers. Lots of different subtypes there, but kind of broad strokes.
why is that?
So immune therapy in some ways works on cancers that have a pretty broad spectrum of mutations within the cells. So in lung cancer, specifically in smokers more than in non-smokers, oftentimes their cancers have a high amount of cellular mutations, right? So we call it a high mutational burden. And so there are more opportunities there for immunotherapy to find abnormal. So in those cancers, it seems like it works well. we're trying to see if radiation can actually help to unlock some of the cancers that immune therapy might not have been helping. But there are other cancers in lung cancer, for example, if you have an EGFR mutation, a very specific cellular mutation, oftentimes in non-smokers, or an ALK mutation, oftentimes in non-smokers for an adenocarcinoma, immune therapy is actually not helpful and actually can be harmful for that patient. They actually can do worse. And that's probably gets down to a little bit that cancer has a very specific cellular pathway that with immune therapy, you're not doing anything at all to target that. We have other drugs for those, but not for all point mutation cancers. There are plenty of that we don't, but we're able to direct drugs at them to help at least trying to slow the cancer down. The other area is we did a number of studies, a couple that I was involved in, where we added the immune therapy right with the radiation treatment in lung cancer. And actually the patients did no better, arguably did a little bit worse in terms of side effects. And it may be because with radiation treatment, we're kind of wiping out the immune system too intensely while giving the drug. So it seems like the timing of when we do these things is actually going to be super nuanced. And that's tricky to message out to a patient, right? As to, because they're going to think immune therapy, get on it now, get on it and stay on it. And, it's really unclear.
Is that still in its infancy, the intersection between immunotherapy, proton radiation?
I think we're past the infancy. I think we're in the teenage, middle school years.
Okay.
I think we've got a lot of science to do to get us to maturity with it. There are tons of open questions about which immune pathways matter. How can we use multiple agents? We've tried a number of immunotherapy trials. In some cancers, we're using more than one drug isn't helpful. So it's not a more is better kind of situation. So there's a ton that we have to learn. And every single one of those questions ultimately requires, some degree of hypothesis generating and experimentation. Unfortunately.
Sure. Yeah. Not super cut and dry topics we're talking about here.
Yeah.
Okay, let's see. Let's talk a little bit about, I know you had mentioned the types of cancers that might be more beneficial for the proton therapy versus the X-ray therapy.
Right.
What about the types of cancers or situations that are best suited for the SBRT or the SRS specifically?
Yeah, so SBRT, smaller to mid-sized tumors in parts of the body that potentially have some redundancy. Okay, so an example would be a section of the lung, assuming the patient has some lung function that they can let slide a little bit without putting too fine a point on it, or the liver, those kind of locations. Those would be the classic examples, although we do it in bones now. Right. And we have ways of adding cement to bones to try and strengthen, because remember, my job is to injure something. So if I injure a bone, sometimes we might want to do something to augment the strength of the bone and the spine in particular. So things where we need to give it a little more of a punch than we might otherwise, we're going to take sometimes a risk for it. So for example, that comes up in a couple of scenarios. So proton treatment, to go that direction for a second, if I have a somewhat resistant tumor, so many sarcomas would fall into that category where we need to hit them harder. So if I can do some normal tissue sparing with proton treatment, that might give me a chance to actually hit the tumor a little harder than I might otherwise with regular X-ray treatment. SBRT is kind of the same thing. I do SBRT with protons also, where not only am I taking advantage of protons, but I'm taking advantage of trying to get in and out pretty quickly. I also do, because it gets into the question of how many treatments is SBRT. I'll do SBRT type treatments for 6, 8, 10 treatments for patients. We don't call it that because, again, in Europe they don't have these distinctions, but here in the States we have these weird, basically billing distinctions about what is and what isn't something. But I use the same basic technique of hitting something hard, tight, rapid dose gradients, fall-offs, and trying to be very durable in the treatment. So.
Yeah, I was just thinking back to your what you were talking about earlier with the amount of treatment sessions. You know, what am I trying to say? Why you would need to do it that way? It sounds like the size of the tumor, how close it is to other vital organs, etc.
Right.
To kind of, because I was getting into my next questions, was the treatment duration, the frequency of treatment, how many treatment sessions they would need. What is the patient experience with these shorter, more intense type treatments versus a more standard treatment protocol?
Probably very similar. Other than the annoyance of having to come multiple times, over several weeks, that obvious difference, right? But in terms of nowadays, the length of time on the table is very, very similar. The immobilization, holding them still techniques that we use, because, we don't just throw precision out the door because we're going to treat them over a longer period of time. So some of the things that we do actually remain consistent. We used to make bigger distinctions about that. And that was because the components of the machine to image, to process that imaging, took so much longer that you wouldn't want to do that every day. But now they're so fast. And the computers are so quick that we're able to do a lot of the same things on a daily basis. So they probably shouldn't notice too much of a difference. They, in terms of side effects, a brain tumor patient, for example, might be a little more prone to nausea from a single treatment near part of the brain that causes nausea than they might from a smaller dose treatment. Similarly, in the abdomen, you might have a similar kind of scenario. Their nausea may not come on for several weeks, whereas with a high dose quick treatment, it might be sooner. But the response to treatment might be a little quicker with a faster, harder hit. We might know an answer within 3 or 4 weeks for something, as opposed to waiting a couple more months.
In terms of re-imaging the patient?
Re-imaging, accelerates the timeline.
Got it.
Yeah.
You had mentioned, I kind of wanted to get into more of the patient experience now, kind of shift gears a little bit. You'd mentioned the immobilization. Walk us through maybe what a radiation planning day looks like in terms of the CT, the immobilization, and mapping.
Yeah. So, to me, the biggest step in the patient experience is trying to make the patient feel like they're seen, they're heard, and everyone in the office is, kind of geared up and caring for them. So that's so I work at UCSD, I work at the North County office in Encinitas. I work down at Moore's Cancer Center in La Jolla, and I work over at the Proton Center. And obviously that experience is easier to do from a management perspective the smaller the operation is, if that makes sense. So, in North County, we're able to provide, a very personalized experience because it's just, we have less employees, there's less variability in who they interact with. We're able to control all of those aspects of care. That's incredibly important to me because you want my job is to make people feel better and be happy.
Right.
So that's super important. Harder to control as the size and scope of the place you're working at gets larger. It's a natural structural issue. But what we try and do from a radiation perspective is, no matter the size of the center, is that the processes and the procedures remain very, not rigid, but they remain very formalized, right? So radiation planning day is going to look the same at the Proton Center as it does at a big university hospital, as it does at a smaller office, where they're going to come in. The appointment is going to be not necessarily to the physician. They might see them sometimes just to say hi, sometimes because I have something I need to do with regard to that. But the backbone of it is we do standardized imaging with the device that we're going to use to hold them still. So for a head and neck cancer, somebody comes to see me for a brain tumor or a tongue cancer or even a larynx cancer, we're going to use basically a plastic somewhat rigid device to hold their head still. The current modern ones nowadays are open in the face. Not at the Proton Center because we have different equipment needs, but at the X-ray centers, they're open in the face. So they're super comfortable, have almost no complaints of claustrophobia with that. It's pretty rare.
Yeah.
It's like wrestling, right? You get a hold of somebody's forehead or you get them around their knees or ankles and you got pretty good control of them, right? So a little pressure on the forehead, a little pressure under the chin, pull the shoulders back, and then that's really all we need to do. So we do that imaging with or without contrast. I try hard not to push IV contrast on folks unless I really think they need it, because there's a risk to everything that we do.
What is the risk of that?
So, well, there can be kidney issues for IV contrast. There can be an allergic reaction, even if somebody's had it before. You can have an extravasation issue. So that means we put the IV in and the IV infiltrates into the arm and they get an injection of contrast into their arm. And then that's a visit to the emergency room. And in my career, I've seen a couple of folks where they have to have a terrible procedure, to open up their arm and, get rid of that pressure in the compartment.
Yes.
So it's things that can escalate to be really, big deals. But, if given safely, it works well and can be a useful tool, but there are many cases I don't need it for. So I don't give it to everyone. But we get the CT done plus or minus the contrast with whatever device we're going to use. So in the body, oftentimes we're using some immobilization to hold their hips still, or maybe even just behind their knees. And then once we're in that position, that's the position they're going to get treated in. And then I can use all their other imaging added to that. I can layer it in. So I can take the MRI scans, PET scans of a variety of types, and I can layer those in with the magic of computers now, so I can use all that information to design the treatment.
Interesting. Are you guys on the note of AI? It's such a big thing now. With ChatGPT and all these Gemini, all these tools out there. What role is that playing in these imaging? And I'm sure it's a very complex process we're talking about.
Yeah. So AI is it's a double-edged sword, right? Because we don't want AI to make us more stupid, right? We're already kind of dumb enough, right? So you have to be careful of the crutch that you're using. So when I think of AI, the general public user of AI, ChatGPT, Claude, any of those products, those are large language models that are basically using predictive ways of trying to get to an answer, right? Not so much for what I do. If I have a patient education question and I want to, get a, just a quick summary, I can go to ChatGPT or Claude and have it, give me a quick, rundown of something. And sometimes that's actually very useful for a patient. What I tend to think of as AI or machine learning in my field tends to be more, so when I design a radiation plan, say I'm trying to treat the liver, okay? So I have to design the area around the tumor. So that's always sort of done by hand or hand assisted. Right? We have computer ways of helping us do that. But then I can use the power of machine learning, which is meaning basically a reference library of multiple scans that can generate auto contours, auto segmentation of the shape of the liver, the shape of the intestines, the kidneys, and that sort of thing. And what I try and caution residents on when I teach this stuff is you have to, again, it's all about process. You have to generate sort of or Dr. Gwandi's checklist of going through. And so I go through and I literally will check each of those structures, with the fineness of the comb depends on the criticalness of the structure, right? But with a jaundiced eye to see what I need to change from what AI generated for me or machine learning generated for me, and then but it helps to speed me up. So what may have taken me 3 or 4 hours of sort of meticulously hand drawing, now I can have a computer give me a draft and then I can work through it. So yeah, it's going to really increase our productivity. I want to make sure that it doesn't decrease the personalization of what we do. And I have my concerns about, are we going to automate our colleagues, out of jobs, right? I mean, so are we going to need less physicians because I can be more productive, right? Possible, although I can only see so many people in a day and still maintain sort of my smiling disposition.
Right.
So, I mean, there's a limit there, right?
Sure.
There are certainly, but ways we can speed that up. So then you need less people, or maybe we can reach people better, right? It's a balancing act.
Right.
But certainly on my ancillary support staff, right, there are going to be, major changes that are going to occur across all kinds of industries, including healthcare, over the next 5, 10, 15 years that I see coming down the pipe that are both exciting and kind of scary all at the same time.
Definitely. I was kind of thinking just along the lines of just the complexity of the treatment and the combinations of the immunotherapy, radiation therapy, proton therapy, all these different techniques of all of those, and kind of just the ability of AI of using all that data to just generate some hypotheses or on that line versus the
for sure. I mean, can we take a patient, look at their genetic profile of them, the molecular and genetic profile of the tumor, and generate some predictive algorithms of how they should get treated on what timeline, using what combination of drugs and to what radiation dose, and is there something about their genetics that predicts toxicity? Oh my gosh, there is so much to learn there, right? But some of it is going to be tough to figure out. So, for example, there are some blood tests coming on now where we can collect blood samples to look at circulating tumor DNA, right? So the challenge, for example, in lung cancer is, this is my interpretation of the data, is it gives us 3 months of knowledge that they're recurring earlier than the imaging, but that what we call lead time bias, right? So we know sooner, isn't changing the ultimate outcome of their care. What we would do, how we would do it, and then the ultimate effectiveness, and then how long they live.
Sure.
Right?
Sure.
So it gets to be a pretty complex, nuanced thing that, again, is more always better, right? And so,
At least, I guess, at this point in time, that lead time isn't really...
Right, but maybe someday it will be.
Maybe someday it will be, yeah.
Yeah, for sure.
Yeah. Let's see. I think we kind of got into some of my next questions. The typical. I guess. Well, let's talk about the typical treatment session. We talked about the pre-planning, and then let's get into the actual treatment. What does that look like for a patient coming in for therapy?
Yeah, so we talked about, do you do a scan to immobilize them, get the imaging you need, so we're going to treat them. They go home, and then for a variable length of time, they're gone, and we're doing the work behind the scenes to get them started.
How long are we talking here?
So anywhere from 2 or 3 days to a couple of weeks. And that varies based on the complexity of what we're doing, the urgency with which we need to do it at, and the complex ability of having enough space to treat them, if that makes any sense, right? So, and obviously the one where, like, I stay until the cows come home, right? So if, we need to stay and be there at 8 o'clock at night because we got to stay an extra, whatever to treat a patient because they got to get started now, then we stay and we do that. Yeah. Right. So that's the one that's the most fudgeable. But behind the scenes, the reason we have time in place there is because I have to have time to do my job to design the target that we're doing. Then it actually goes from me, after I aim and tell them what we're aiming at and what I want to miss. It goes to a person called a dosimetrist. They do a lot of the computer-aided design work that they then come back to me with. So there's an area where AI might change that interaction someday, where I just do the planning. So the dosimetrist does that component of work. I review it, maybe do an iteration or two to make it better, hopefully. And And then from there, it goes to a medical physicist, which is generally a PhD, often sometimes a master's level person, who then checks the safety of the plan. Is it feasible? Is it just crazy Dr. Urbanski again coming up with, magical idea of what he can do? And then oftentimes before the patient ever comes, then we're running a mock plan of their treatment and measuring the delivered dose of radiation. So when they come in for that first treatment, it's already been run at least one time, in addition to all the other daily checks that we do on the equipment to make sure everything's in place. So that, we like to have time because we try and create a culture within the process that anyone at any time can say, hey, I don't like what I see, or, hey, maybe you could do this a little bit better, right? So, like, for example, today I was doing some work this afternoon, and, one of the dosimetrists emailed me and said, hey, Dr. Urbanik, I was looking at your plan on these brain tumors. I saw this little spot on the MRI scan that you didn't include. What do you think about it? And then so I take no offense to that, right?
Sure.
I go and I take a look at it, and and then for this one, I thought it was a little blood vessel. I said, I think it's a blood vessel. Let's go ahead and we're just going to watch it. And we have this other stuff that we need to treat. And so on we go. But, if you have the wrong environment and someone's afraid to ask the question, that's not what you want.
Right.
And so part of that is allowing time for that to occur, because also if everyone's rushed so much, then you don't have time for that to happen. I'm also, maybe I'm just getting old, but I like to sleep on things. So, somebody might look at me like, why, hey Jim, why do you like to contour some of your normal tissues by yourself, by hand, and blah, 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 and that sort of thing. And I would say, well, because I sit there as I'm contouring and drawing and I'm looking at their scan, as my head, I'm kind of thinking about what I want to do, and maybe changing my mind a little bit or coming to a different conclusion. And that's happened to me countless times where I kind of take a little bit to digest, kind of step back from the busyness of the day and then adjust what you're doing. So, it's sometimes annoying for patients, the time factor, but for me, it's not just engineering. There's a creative process to it that you're trying to allow to occur. So, which I try and tell my boss, we're not just, widgets, generating radiation plans. You have to allow, people to try and, think about what they're doing and why they're doing it. So,
yeah, an art and a science to it.
Yeah,
I think maybe a lot more preparation than I had originally realized. Quite extensive, it sounds like.
Yeah, you wanna, patience is a hard virtue.
Yeah.
And part of that is the longer you do this, you get victories that you remember, right? And, some big victories, right? But you also get some terrible defeats,
right?
Both where, the cancer wins, if you will, but also where, hey, I may not have made the most optimal decision. And I'm not talking medical error and malpractice. I'm just talking like, are there more nuanced ways to have thought about that problem, right, on a daily basis? And being able to look at yourself and continually try and reassess and improve is also part of the creative process of doing it, right?
I'm just curious, what's a normal day in your life look like? How many of these are you typically doing in a given day? We're talking, proton therapy.
Yeah. So I'm getting older. So I get more administrative as I get older, right? That's just and a natural progression. But for a long time, I had 2 days a week at the Proton Center out of 5 formal working days, although I work on weekends plenty. Now I'm basically doing 1 day a week at the Proton Center to try and manage the number of patients that I can practically care for at any one time. So I'll generally see 2-ish, so 1 to 3 new patients a week for proton treatment specifically at the Proton Center. And then I'll maintain anywhere from, at the Proton Center, from 6 to 10 folks on treatment at any one time, which for me is a manageable amount. I also get patients where I see them at the university, and for whatever reason, they're going to need proton treatment, or we have that conversation, because I'm the main doctor for adult sarcomas, for radiation therapy at UC San Diego. So typically those folks come to see me oftentimes on a Monday over at the university, and then I'm shunting them over to the other facility for those problems. So I have my schedule kind of scripted to do that. So that's for on a typical day, but my day generally starts, I try and swim in the morning. I go surfing, before work. So getting up at 5:30, getting out of the house at, 6:15, getting into the office 7:30. And then I generally most days work until 7:30 at night. Usually patients all the way up until 5 or 6 o'clock, and then trying to catch up on some of the paperwork. And then, nowadays I generally take at least half a day on the weekend to work. And when my kids were little, I used to wait until they went to bed and then go back to work. So, it's unfortunately just like, my work is like a big part of who I am.
Sure.
Right? Because I kind of live there.
Yeah.
But I mean, when I lived on ships, I was worse. Because I would go to sea for, a bunch of months, and I was always working. So this is an improvement.
Yeah. Let's get into, let's see. I think we talked about a little bit of the side effects. Maybe let's touch on that a little bit. Just some common side effects. So let's talk about both short-term side effects, long-term side effects, and how do you help to manage, or how do you help patients to manage those?
Yeah, well, it depends on what we're doing, obviously, right? So the most common one that kind of spreads across diseases is skin reactions. From none for some deep-seated small target tumors, the patient's going to get no skin reaction, to pretty darn wicked skin reaction where the skin can like dry blister, typically not a puffy like heel blister thing, but like it's this dry, weak area on the skin, and everywhere in between, right? The thing, at least to this point in my career, the skin always heals. It may be a little bit discolored, could be a little stiffer, but it always closes, right? It always heals in that respect. So that's a universal. So we talk about that. Proton treatment, the skin reaction is generally worse than it is with X-ray treatment. And we have ways that we really try and manage that through designing our plans. We've learned over the years how to do that. And so the easiest way to think about that is if a wave is giving up its energy as it goes into something a little distance before it really starts to give up energy, right? Kind of makes sense. A proton is a ball, it's a particle. It interacts with something right at the surface, right? So that piece of it, and then the way it actually does ionization, it's a little more directly ionizing. So the injury is a little more billiard ball-y, if you will, with a particle than it is with a wave, which is more of an indirect ionization. So the skin reaction tends to be more obvious in proton treatment. It's a downside. So breast cancer, that's a big deal, right? And you have to be able to talk about that with folks. So then it really is a matter of what we're treating. So, for, men and women and the pelvis, we're talking everything from sexual function to, injury to the rectum or bladder, either temporary or long-term. Thankfully, most things are temporary, right? So prostate cancer, somebody has to go up and go pee more often for a few weeks. We have medicines we can try and minimize that, but in general, they're going to get better. Right? Not always, right? There are some big risks always, right? Sure. But, or the risk of rectal bleeding for that patient might be less than 1%. So not zero, but a small risk, right? But you may have other cancers where, if I treat a tongue tumor, they may come in where they're talking normally, swallowing relatively normal, but they have a tumor that if you were to take out with surgery would totally destroy their tongue. right? It would be terrible, right? So we treat it with radiation, but we know going in that they're going to have long-term alteration of speech, taste, saliva, how they swallow, all stiffness in their neck, the risk of narrowing of their carotid arteries, all kinds of things that go along those lines. And so you just have to try and be honest with people.
Yeah. So highly variable then.
Highly variable. But the easiest way to think about it is, my job is to aim at something and injure it. So whatever that is.
Let's talk a little bit about the concept of re-irradiation. And, many people are thinking, if I've had radiation once, I can't have it again.
Yeah.
Is that true?
Well, so like everything, partially true. So for something we're treating as the main treatment for cure, so like a prostate cancer that's not having surgery, we're going to give it a lot of radiation the first time around. So more radiation the second time around is going to be really hard to do, and the risks of doing that are going to start to go up. So, and I use prostate as an example because they may have other options instead of re-irradiation. There may be focal cryotherapy where they freeze it kind of treatment, or an ultrasound kind of treatment. They may have medication options, although those are oftentimes not super exciting for people because they get rid of testosterone.
Right.
But they may have other options before I take the option of hey, I could put a hole in your bladder or rectum or make it terrible for you to pee, right? So there's an example where we have other options. So for example, re-irradiation of the prostate, I tend to be, my own personal practice is very hesitant to do that. Now somebody comes to see me and they have a lung cancer, they have a relatively small / modest size recurrence, and we've run through our list of immunotherapies, drug options, surgery may or may not be an option because of the risk to the patient. And we're faced with, hey, that's the only site of cancer that you have, and if I do nothing, it's going to spread and be terrible.
Right.
Then we're going to take the risk of retreating it. And I've written some papers on that. And I have an honest conversation like I did last week that, hey, the risk is that I could cause a blood vessel to bleed and you could die. That's a risk of treatment. Right. And I can't predict who that is going to be, or if that's going to be the day after treatment ends or 4 months from now. But I know that if we don't treat this, we're just acknowledging we're going to let the cancer progress, and then maybe your option would be to consider radiation to just slow it down with a lower dose, perhaps later on. And so then we have to talk about what their goals are and why we would want to do that one way or the other, and that's hard conversation. In tongue cancers, throat cancers, oftentimes we're willing to take some pretty big risks with re-irradiation because recurrent cancer in the head and neck region is really, really hard to treat and can be quite disfiguring and just terrible, right? And so when we do radiation, sometimes we can't do repeat radiation in the head and neck area, but when we do, sometimes we're going to take some really big risks around their carotid arteries, their tongue function, injury to the jaw, and I've taken some of those risks, and sometimes I've been very happy with the result, and sometimes it wakes you up. I don't think I have PTSD, but I certainly remember all those situations. They're tough. So
I can imagine.
Yeah.
I was just thinking, something came to my mind as you were talking about that decision-making process of, treat now versus, and possibly have a better outcome, also risking, some pretty significant risk there too, you mentioned. Do you have any decision-making models? I mean, how do you, I'm sure that's obviously a process with the patient, of course, but how do you think through those decisions?
Yeah, well, you have to rely on the body of medical literature as it is, as weak as it is, or strong as it is. You go and you look what other people have done and reported on. And I think one of the things that my field does reasonably well is reporting on our toxicities in the literature. So, for example, there was a group in Scandinavia that was doing a Re-Irradiation paper. This is a bunch of years ago now. And they had actually treated a couple of patients for 3 courses of radiation for a pretty resistant tumor. And they had a couple of those with terrible toxicities. But they reported that in the medical literature, right? That's super important to let people know, hey, that was too much.
Right.
Like, don't go there. So you have that. You have the hard-fought experience to fall back on. But anecdote and treating based on the last treatment you did is never a great place to be.
Right.
But that is one of the tools in our toolbox. You have your colleagues. You talk to people. You review cases with them. You scratch your heads about it. And you're also trying to get a sense of the person the patient, the person you're dealing with. What do they want to do?
Right.
You're gonna meet some people that are like, "Hey, I get it, but let's go. Like, let's do this, right?" And they're in the lists of risks are real. And then you have other people that are going to be like, "Yeah, no, I'm really interested in quality of life," and that's a complex statement. I'm interested in quality of life because sometimes they don't know the truck that's coming down the highway at them.
Right.
So you have to sometimes try and work through what they mean by that. But at the end of the day, they want a less intensive approach, which is perfectly understandable. And then there are some patients where you have to be honest that, like, hey, being super aggressive is probably not in your best interest. And I've certainly had plenty of those conversations where it doesn't make sense to try and do this. I'm just going to hurt you.
Right.
I'm just going to torture you for the last whatever period of time. So.
I want to shift gears a little bit and talk about, I'm in functional medicine, and so, diet, lifestyle are a big part of my practice. What role do you feel that diet and lifestyle play in people in terms of their outcomes with radiation therapy?
Yeah. Well, I'm a big believer in control the controllables, right? So we've got pretty good data on exercise to start with, right? For outcomes in breast cancer in particular. And we tend to have better data on things like that in disease groups that have a better prognosis, sort of for obvious reasons, right? Or the patients are able to do things like exercise better. But, I don't think it's too crazy to extrapolate that experience more broadly, that exercise is great for the mind, the mind-body connection, your immune system, cardiovascular, blood flow, all the rest, right? So it's cheap and easy. And I don't mean I got to take, my mother-in-law and turn her into a marathon runner, right? I mean, let's get you off the couch and get out and do half an hour, 45-minute walk around the neighborhood and moving and grooving and that sort of thing. People ask me what's the best exercise I can do when I'm radiation treatment, and I say, well, whatever makes you happy, first of all. And then I say, if you're going to pick, as long as your skin's intact and you can, swimming is like the best exercise ever invented. Now, I would agree with most people that swimming a long time is super boring, but it's easy on the joints. Great to focus your mind on something else and get you moving, right, in a low stress way. So I'm a huge fan of exercise. Diet is a tougher nut to crack, right? Sure. So I tell people, like, hey, you're not going to see from me a cabinet of like stuff to buy right behind me. But I will tell you, hey, if you can afford going to Sprouts or Jimbo's or the farmer's market, and unless the farmer's spraying pesticide on it, God only knows, right?
Sure.
But and you can get better product, right? Great, right? If you can afford that, right? Because we have huge problems, especially in our most needy communities, of food deserts and terrible diets and things that are really structurally hard to fix. But if you can, eating cleaner, healthier food, staying out of the middle of the grocery store is the easiest way to counsel somebody on what to eat. And then I would tell them, if you can shy towards a higher protein, lower carb diet, it seems like that is the direction to go. To try and get, one of my patients, in the midst of the terror of going through cancer, to go ketogenic and add sort of the stress of going all that direction of full protein and sort of that direction is very hard to do, and to get people to stick with it. So I try and talk to people about things that they can do over the long haul. And I think that's reasonable. And then, give people the ability to enjoy life also. Like, hey, if you go to McDonald's and get a Big Mac, and it's once a month, don't beat yourself up over that.
Right.
Right. Or you went to the ball game and you got a tall beer and a pretzel, you're going to be okay.
Yeah.
So that's kind of how I approach it.
Yeah. Have you seen any differences in the nutrition, or let's even, talking about, frankly, mindset, or, not to get too esoterical, but, what role or what have you seen just in your practice over the years that you've been practicing, people coming in with certain characteristics in their lifestyle, for instance, and then what role do those play, or what are some of those things that you've seen statistically have a meaningful positive improvement on their outcomes?
Yeah.
If you've seen anything like that.
I mean, there's some data on yoga. There's a little bit of data on Reiki, I think are positive. I think they're positive from a physical standpoint of doing the exercises for yoga and the stretching and the strengthening, but also from kind of the clearing the mind kind of standpoint. I think those are all super important. Any techniques we've tried over when I say we, I mean the royal we. I was actually a part of a sort of a group at Wake Forest when I was there that was trying to do studies not of cancer treatments, but of sort of complementary things that we would do. So I actually tried to do the study on how Reiki interacts and yoga, and some, there was a device to try and help calm the breathing for lung cancer patients a little bit. They're very hard to do and get meaningful data because they depend so much on patient-reported diaries and outcomes, and then tabulating those results in statistical ways. But anecdotally, I think any things that can try and take the stress and the anxiety of the treatment down a notch is going to help their outcome. Yeah, for sure. And that's part of where I get back to like the center itself, where you work, right? The staff being, pleasant and happy and outgoing, and all of those, the whole environment, really matters.
Yeah, because I'm sure it's a extremely stressful, fear-inducing time for the patient.
Right. Yeah. It's kind of interesting. You always have to be mindful of what you say. I said for one patient, I said I'm going to try and make this really boring for you, and they interpreted it. They thought I meant it was boring for me, as if I didn't wasn't interested. And no, and thinking in my head, it was like it was misconstrued as things you say can, but that really is a goal. Is we want to make it like as boring as possible. So, sometimes with we're talking about proton treatment, and it does have more complexity and downtime and things. Sometimes the complexity and the downtime drives me bananas because it adds to the stress of the patient's care. Right. Because then they have delays, they're waiting, they might miss a day, we're adding it on at the end, and in reality, I really want it to be like boring. Right. I want it, you get on an airplane, you don't want the pilot up front to be, like, hey, that was the most exciting plane ride I've ever been on. Yeah. Right. Yeah, you want boring.
Good analogy.
Same idea.
That makes sense. Maybe let's talk about the future. I think, are there any new and exciting, research or clinical trials that you're particularly excited about?
Yeah. Well, there are lots of things. I mean, there's
Sure.
1,000 directions,
Yeah,
right?
yeah.
So I'm excited, and apprehensive because it's embarking on a new thing in the United States. They're going to have a carbon ion center in Jacksonville, Florida, at Mayo Clinic.
Okay.
So using a heavier particle that they're already using in Europe and Japan. It has probably some different biology because now we're talking about carbon is a big molecule, big atom, right? Compared to a proton, which is the center of hydrogen, right? So that's kind of exciting from a technology, engineering, treatment delivery standpoint, and you can't just take a proton center and convert it into a carbon center because if you think about it, you're throwing around a much heavier particle. So the scale of now the cyclotron and the magnets, it's actually a synchrotron and the magnets, it's getting even bigger.
Wow.
And more expensive and more, right? So I'm excited about it from that. I'm apprehensive in terms of, the arms race that sometimes occurs in all of medicine.
Right.
We have this, you don't. This is better without data. I'm very data driven, but I'm excited about it from just the sheer science of it and the cool factor. Immunotherapy, for some cancers, single biggest advance in the past 50 years for cancer.
Really?
Right? Patients who would have been dead are now living because of immunotherapy. So, and how we integrate those and what are the new drugs that are coming down to do that. I'm super excited about some of that stuff. In radiation, we're actually going back to the table again, if you will, and looking at, hey, with immunotherapy, are there actually lower dose ways that we can manipulate radiation to stimulate the immune system without causing actual killing the cancer, death, but trying to trigger the immune system? That's pretty exciting. It would be a totally old dog, new tricks kind of thing for me to go from like trying to hit something as hard as possible now to trying to just be gentle for the medication.
Just triggering that immune response, if you will. Yeah.
Yeah.
Okay.
Interesting, I think the science on that is going to be, we're going to need to be, very careful on how we do that. But it's exciting. I think AI, large language models, machine learning stuff, it's going to affect all of us. It's going to affect, whether or not this podcast 10 years from now is going to be just AI generated as opposed to two human beings talk to each other. It might even 5 years from now from what I was seeing versus my field, like, how that's going to affect us. And we're going to have to adapt as a society to how we do that. I think those are important. I'm super upset about the changes in, our federal research environment right now, how we support universities and science. I think a lot, I can't say all because, there's no such, all is a terrible place to be, in terms of how you look at things. Right. But I think a lot of the changes that have been going on in terms of the NIH and the NCI and how they're supporting people's careers and the questions they're able to look at is super impacted right now. And I think we need to turn a lot of that around. I think Congress is supportive of that. I'm not sure about the current administration, without getting too far down that rabbit hole, but that really has me bummed out. So
some positives, some challenges ahead.
Yeah.
Okay.
Yeah, for sure.
Fair enough. We talked about AI, which was my next question. So I think we'll skip that. But maybe looking 5-10 years ahead, what do you think is the next big paradigm shift in your field to come?
Wow, 5-10 years from now in radiation oncology. Well, the population's aging, So the challenge is we're going to still be busy. And so the challenge is how are we going to meet that need? And I don't think that's easy. I think, AI, I think efficiency things are going to help with that. But I think we're going to see a continued crisis in the United States, particularly in rural areas where folks are going to be stuck with less access. I think that's irregardless of politics and has everything to do with just changing demographics and availability of things and limited amount of resources to go around, right?
Do you see proton therapy centers? Actually, how many are there in the States?
So I don't have the number handy, but it's in the 50-ish range.
50-ish. So not too many.
And they're not geographically dispersed, right? So, I joke you could probably get off at every major metropolitan area on I-95, running from Maine to Florida, and you'd find a proton center in every single one, right? Here on the West Coast, much fewer. We have an older center in Seattle, so they have some technology issues without throwing them under the bus. We have us in San Diego, and we have Loma Linda, which is very old technology. And then we have Salt Lake City with a small single, soon-to-be two-room, so a smaller center there, in Mayo Clinic in Scottsdale, and then that's it in the West, without going on the other side of the Rockies. So for the population out here, we're certainly underserved for proton therapy. Yeah. There are a lot of myths that go into why that is, as well as some truths buried in that. So they made a critical mistake in San Diego building too big, which then I think scared off future investment in other maybe more smaller, more nimble opportunities in the state. I think that was a huge mistake. Wasn't my decision. But, the costs in California are tough, right? The building costs, real estate costs for land costs. Right. And then we do have an earthquake issue, which has to be mitigated when you build. So San Francisco, they're building a proton center. It's going to be, I think, 3 rooms. I want to say 4, but I know it's at least 3 rooms up there. They're building it down kind of near where the stadium is and then the basketball arena is, because that's on bedrock in San Francisco, that region, right? But we have to deal with that in San Francisco and Los Angeles. And we're a big state. We're a rural state, California. So that'll help for us. I think that's actually a good thing, right? All ships rise with the tide. Right. Take some of the pressure off of us for pediatrics and expand access for people in California and the West. Technology is going to help with that, where the centers can get smaller now, more cost effective. The cost of ownership is going to, go down from hundreds of millions of dollars down into the tens of millions of dollars to build one of these centers. So that's going to help. But it's not going to replace X-ray treatment, and we have to do the research. Sure. I'm careful that I'm not a proton evangelist. I know plenty of people in my field who are. I try and maintain my equipoise, even keeled. That it's incumbent on us to do the research to prove when it's effective or when it's not effective. And sometimes that's going to be randomized trials, right? This treatment versus that treatment. Sometimes we're not going to be able to do that because of the rareness of the disease. I would be careful that it's not like proving parachutes, right? So there's in my field, there was a famous editorial once written that proton therapy is like parachutes. You don't need to prove that they work, right? I think that is like an overstatement. But there are other forms of research, that I think, single arm longitudinal follow-up studies that can contribute to the medical literature that can support why we do one thing or the other. So for sure.
Very exciting stuff on the horizon here.
Yeah.
Very exciting. Couple kind of maybe rapid fire questions for you. How about what are a couple questions that every newly diagnosed patient should ask their radiation oncologist?
That's a tough one. right? And sometimes a patient will throw back to you that classic question of what am I not asking you, which is kind of a funny one because there's an implication in there that I'm withholding something, and I think just from our conversation, you can tell that I kind of just roll.
Yeah. Appreciate
So
that.
I think they need. I think what people need to look for, more importantly, in the care team or the patient or the doctor that they're getting, but more important, the whole team, is do they seem like they are listening to them? Do you feel like they're on top of their game, meaning they have a grasp of kind of why you feel like when they explain why they're doing something, they can give a coherent answer to that. And you feel like you develop that sense of trust, right? And so whatever questions you need to ask to not test the trust in some kind of weird way, but to try and pull that out a little bit, is important. And sometimes I like it when patients come with, they've done a little bit of research, and they'll say, hey doc, why aren't we doing this with, Sabre, right? So, and we're going to do this with SBRT. And then I have an opportunity to tell them that they're the same thing. And we can talk about that. And, I tend not to use the newer term Sabre because it feels too marketing like,
Sure.
So we have a little bit of that conversation. So it's not, is there any one thing they can ask, but other than trying to ferret out for them, do they feel like they can trust this person? Right.
That's a really good answer.
Yeah.
What is it that you sound very passionate about what you do? What keeps that alive for you?
A few things. I hate to lose. I'm not good at it. So I come to work with the idea that I'm going to work hard every single day. I also, you think about life and mentorship. So I'm named after both my grandfathers, James and John. And my mother's dad was a physician. He actually died in 1969, to give you a sense of how old I am. And I that was the year I was born, so I never met him. But the story that my father relates to me about my grandfather, so his son-in-law, was that, and there's probably a little bit of family mythology with this, right? But the sense that he would take him to work in the last couple of years of his life. And he had a cane, and he was a balding, gray-haired gentleman at that point, a little overweight. But he would leave the car in the late 60s for my dad, and he would hand him the cane to walk into the hospital, with the idea that, he's at work and he's on his game. And he's the doctor, and he's there to try and solve the problems, and his problems are not their problems. And so I try and kind of live with that lesson, if you will, that I've been given this opportunity in life to learn and use the skills that I have, and I try, and I'm certainly not perfect, but I try and use them to the best of my ability every day. And so every single person sitting in front of me, whether they have the simplest thing in the world or the most complicated thing in the world, they get the same respect, from me and from what I'm doing, right? So just try and do that, and then I want to win.
Do you? I know you have multiple things that you're doing.
Right.
What do you find the most joy in? I guess I know you're teaching, educating, you're treating.
Yeah. As I've gotten further into my career, frankly, it's more and more just plain old patient care.
Patient care.
Right.
Yeah.
I'm people can look at my CV. I'm on plenty of big committees and this and that, and have spoken at on big stages. Honestly, I don't care about any of that stuff anymore. I'm more excited about just getting up and trying to just do a really, really, really good job every day. And then, when I do get residents and med students with me, trying to, if I don't have them for very long to teach them all the skills of the trade, at least try and teach them the joy of the work that we do. Because some people will meet me and they'll be like, "Oh my God, you're a cancer doctor. That's so terrible and depressing." And I was like, no, it's awesome. There's a lot of awesome, good things that we do. There are many, many hard things in our conversations, but
Sure.
you just have to love it, and you have to be resilient. You have to be able to put terrible things to bed, but you gotta be willing to do it. Somebody has to do it.
Right.
So that's what I enjoy most nowadays, is just the daily work.
Great answer.
Yeah.
If there's maybe one thing you'd like the listeners to take away from our conversation today, what would that be?
Oh gosh, probably make sure when you're talking to a cancer doctor that you feel like they're looking at all the tools in their toolbox, right? And they're willing to talk to you about all the different tools. And sometimes the screwdriver or wrench that you're thinking about using are not the right one, and they may have a different suggestion for you. Or maybe you have the best suggestion and they need to listen to it. But I think that's important, is just to make sure as you're talking to doctors, make sure you're establishing that relationship that you've got somebody who really wants to, figure out what's right for you.
Anything that you're currently working on that you'd like the listeners to know about?
Oh, gosh. I mean, probably the work, like I guess the more researchy work is, I'm the radiation lead for one of the big NCI cooperative groups. And I think the work that we do there to try and take practical research ideas from either from the pharma world or from university hospital settings and actually try them on a national basis, big trials. That work is so important and needs to be funded, because that's how we answer the big fundamental questions of, do we need surgery in that disease where you're going to need hundreds or thousands of patients to test that question? Or does this new drug work against that standard, older drug? We need that process to work. That's a group that I work with, and when I'm on meetings with them from around the country, that's like the professional thing that I'm kind of most proud of, is trying to help lead that group forward. But right now, we're in jeopardy across all these groups that are funded at least partly by the federal government of going bye-bye, and that's just a terrible opportunity lost.
Yeah.
So.
Where can people find out more about you, about, maybe if they, or yourself, or even, proton therapy, any, particularly helpful resources for people?
Yeah, for sure. So me, I'm not on social media.
Figured you might say that.
It keeps me sane and safe.
Yeah.
I mean, I follow my kids on Instagram a little bit to see what they're up to, but that's about it. And they're probably not there much anymore anyway. So me, you would just Google me at the University of California. And of course I'm happy to see people, as time and space allows. Proton therapy, I always tell people to be cautious about, marketing-based websites, right? Specific industry advocacy groups. I try and tell people that big national groups that have patient-facing information are useful. So the National Comprehensive Cancer Network has patient-facing information, super helpful. The Livestrong organization, which was Lance Armstrong's old organization.
Sure.
Particularly for young adults with cancer, oftentimes has some great resources. I think those are good places to start, and kind of go from there.
Perfect. Well, anything else that you'd like to add before we close?
No, I'm good. Time for dinner,
Okay.
man.
All right. Well, thank you so much.
You're welcome.
We really appreciate having you and your very, very, dedicated, hardworking, impressive, very impressive career. So just want to thank you so much from the bottom of my heart. And also, I'm sure the listeners have really, really appreciated this one. So
Yeah. Oh, happy to do it.
definitely.
All right, sir.
I just want to say thank you so much for finding us. We're building a place to talk everything cancer, and since we're just getting started, there's one small thing that you can help us grow. Hit the follow or subscribe or review or share button or whatever button wherever you're listening. It really helps this project reach more people who may really need it right now. On top of that, tell us what you want to hear about, and we'll do our best to deliver. By the way, we share perspectives and stories, but never medical advice. So please talk to your medical team for guidance.